Hello, I am Dr. Srinivas Kasi from Bangalore. I have a special interest in vaccinology and I've been a member of the IAP COI between 2011 and 2013. Welcome to this discussion on typhoid vaccines. The last couple of years have seen some exciting developments in the field of typhoid vaccines. Developments which have the potential to have a tremendous impact on the burden of typhoid in countries where these vaccines are proposed to be used. So over the next couple of, say, half an hour or so, I will be dealing with the burden of typhoid fever, the available typhoid vaccines, what is the latest follow-up data, the 5-year follow-up data on typhoid conjugate vaccines. I'll discuss the latest 2018 WHO and the ACVIP recommendations, and finally some concluding remarks. Typhoid is a disease of the most developing countries which have a very poor supply of potable water and environmental sanitation. The highly endemic countries for typhoid are basically in South Asia, Africa and in the South Pacific, where the incidence of typhoid is in excess of 100 cases per 100,000 population. In the Western countries, which have a very high level of environmental sanitation, typhoid is never endemic and is basically a sporadic disease. It has been estimated that there have been between 11 and 21 million typhoid fever cases and approximately 1,45,000 to 1,61,000 deaths annually. This was an estimate made in the year 2013. A very recent data in a study done between 2003 and 2005 by the WHO in 5 countries with the highest burden of typhoid has revealed typical characteristics of typhoid fever in the developing countries. One of the places included was Calcutta, the slums of Calcutta in India, and the incidence of typhoid, that is blood culture positive typhoid by back check, has been the highest in Pakistan. In India, the incidence has been about 214.7 per 100,000 population. Some of the characteristics of typhoid fever from these study slides are indicated in this particular slide. What is remarkable is the very high incidence of typhoid in India in children below the age of 1 year. It's to the tune of 89.2 per 100,000. And this is one of the highest in the world. A lot of other data exists about the incidence of typhoid fever in a country. Studies coming from Delhi areas have revealed a very high incidence, whereas those coming from Calcutta and the more recent studies have revealed an incidence of 136.7, and the present WHO study which has indicated an incidence of about 214.2 per 100,000 population. Coming to the age incidence, in the Western countries, typhoid has a uniform incidence in the first few decades of life, whereas in the lesser developed countries, typhoid is basically and predominantly a children of an infection of school-going children. Almost 10% of cases are below the age of 2 years. In an unpublished study mentioned in the background paper on typhoid vaccines for the SAGE meeting in October 2017, has revealed that almost 27% of cases of typhoid are found in children below the age of 4 years. Of these, close to 30% are below 2 years, 10% are below 1 year, and in 3% it's below the age of 6 months. So we have a very high incidence of typhoid fever in the preschool going children as well, and even in young infants. The next major issue about typhoid fever is the high antimicrobial resistance. Resistance to chloramphenicol appeared in the early 70s. Multi-drug resistance to the first-line antibiotics, that is chloramphenicol, ampicillin and chlorotrimazole, first started appearing in the 80s and peaked towards the mid and later part of the 1980s. And some of you all who have been practicing for more than 30 years do remember the large outbreaks of multi-drug resistant enteric which appeared in the late 1980s and early 90s. Subsequently, antimicrobial resistance, the first line antibiotics have been reducing, but the antimicrobial resistance, the fluoroquinolines, have been increasing and now stand somewhere at about 30%. Fortunately, antimicrobial resistance to the cephalosporins, specifically the third generation cephalosporins, have been very, very low. But this situation may not continue for too long. Recently, there was a report from the Sindh province in Pakistan of an outbreak of enteric fever. Over 300 cases in November 2016, which had an extended drug resistance. These isolates carried both plasmid-bound and chromosome resistance genes that collectively conferred resistance not only to the first-line antimicrobials but to parenteral ceftriaxone as well. Hence, the only remaining reliable oral first-line antibiotic available was erythromycin. In such a situation, fallback antibiotics would be antibiotics like the carbapenems and tigecycline. Analyzing this particular situation in a very, very thought-provoking editorial titled "The Gathering Storm, Is Untreatable Typhoid Fever on the Way?" the author Levine mentioned that the Pakistan outbreak caused by a multi-drug and extended spectrum strain of Salmonella typhi has given us a clarion call that we are rapidly approaching a scenario where the acquisition of one or more resistant genes to azithromycin might result in a Salmonella typhi pathogen that is in practical terms virtually untreatable in most developing countries. This would return developing countries where typhoid is endemic to a pre-1948 scenario in which the mortality rate was in excess of 15%, whereas with adequate treatment, the mortality is less than 1%. How expensive is typhoid to treat? This was a prospective surveillance study carried out in an urban slum in Delhi way back in 1996. Where the cost of treating one OPD episode of enteric fever was close to 3,500 rupees. And treating one inpatient episode of enteric fever costed about 22,000 rupees. This was at a time when the dollar was 35.5 rupees. And today it is hovering between 72 to 75. We can very well imagine how expensive it is to treat enteric today. So basically, if you look at the burden of typhoid, both the morbidity and the mortality, the morbidity is in no way less than that caused by Hib and definitely more than that caused by other conditions like Hib or for that matter tetanus or meningococcal or dengue. But if you look at the mortality caused by enteric fever, it is far in excess of those caused by either Hib or hepatitis B or dengue hemorrhagic fever. So basically, typhoid has always been neglected as a vaccine preventable disease despite having a very, very high burden. With this in the background, let us now consider how can we prevent typhoid fever today. Most policymakers agree that routine health use of typhoid vaccine should be integrated with other control measures. Now, these other control measures, which are more permanent in nature, includes access to safe water supply and sanitation, hygiene education, and food hygiene measures. These measures give much slower results, require significant behavioral changes, and requires significant investment for creating the infrastructure. On the other hand, vaccination is a very attractive proposition, quicker results, affordable, cost effective, and does not require significant behavioral changes. But what we must remember is that these two modalities are not exclusive but are complementary to each other. While vaccination gives quick results, the other parameters gives us long-lasting and permanent results. Typhoid vaccines have gone through a series of developmental stages. The first generation vaccines, which were mainly heat-killed or acetone inactivated vaccines, were fairly effective, 51 to 88%, but they were highly reactogenic and were withdrawn from clinical usage in the 1990s. The second generation vaccines, which were the only preventive measures against typhoid till very recently, includes the live oral vaccine, which is no longer available in our country, but has the disadvantages of multiple dosing, a very strict cold chain requirements, and the fact that it could not be used in children below the age of 6 years. The other available vaccine was the VI polysaccharide vaccine, where a single dose was effective in preventing typhoid fever to a great extent. The efficacy at the end of year 1 was around 69%, efficacy around year 2 was 59%, but the cumulative efficacy over 3 years was just around 55%. Secondly, it could not be used in children below the age of 2 years, where there also exists a significant burden of typhoid. And the other disadvantage is the multiple dosing and the shorter duration of protection. In spite of these shortcomings, the SAGE in its 2008 recommendation strongly recommended the use of the VI polysaccharide and the Ty21 vaccines for the control of typhoid in endemic settings and endemic countries as a routine public health measure. But this has not met with much success, and the acceptability has been pretty poor for the reasons mentioned before. We now welcome the third generation of the typhoid vaccines, which are the conjugate vaccines, and this to a great extent fills up the gaps created by the polysaccharide vaccine. Why do we conjugate a polysaccharide antigen? A polysaccharide antigen is conjugated to a protein antigen by a process called conjugation, which is a process wherein a poorly immunogenic molecule, that is a polysaccharide, is covalently or chemically bound to a carrier protein, thereby increasing its immunogenicity. Basically, what you are doing is you are tricking the immune system into believing that the polysaccharide antigen is a protein antigen, and the immune system gets tricked and starts processing the polysaccharide antigen like a protein antigen. And as you know, the T cell response induced by a protein antigen is far superior to that elicited by a polysaccharide antigen. You get very high antibody titers, which are predominantly IgG, very high avidity antibodies, pretty good cell-mediated immune response, a longer duration of response, a very good anamnestic response with boosters, and most importantly, a polysaccharide conjugate vaccine can be used from as young as 2 months of age. With this in mind, various conjugate typhoid vaccines have gone through the developmental process. The first one was the VI antigen conjugated to the exotoxin of the Pseudomonas aeruginosa, popularly known as the Vietnamese vaccine. Very extensively studied vaccine, where field efficacy studies revealed an overall protective efficacy of close to 87%. For various reasons, this vaccine has never been developed and marketed. The other one is the next vaccine is the VI vaccine, again extensively studied in countries like Pakistan, India and the Philippines. Though this vaccine was shelved for a pretty long time, it is now being developed by some other developing country vaccine manufacturers, including a couple of companies from India itself. What we are now familiar with is the VI polysaccharide conjugate vaccine, which is conjugated to tetanus toxoid, the 25 microgram one, and we also have a 5 microgram dose. We must remember that all the long-term data regarding the typhoid conjugate vaccine is from the particular brand called Typhoid TCV, which I will be discussing in a little greater detail in the next few slides. In 8 centers in the country from 3 states, that is Andhra Pradesh, Karnataka, Gujarat and West Bengal, it had 2 arms. One was the open label trial, which was in children between 6 months and 2 years, where there was no comparator vaccine. The second group was a randomized controlled trial, which included cohorts aged between 2 years and 45 years. This was a double-blind randomized control arm with a comparator vaccine, which was a polysaccharide vaccine of the same company. A long-term study has also been undertaken, with periodic follow-up up to 5 years following administration of the vaccine, data for which is available today. In this particular study, a sub-cohort at day 70 were given a booster dose either of the typhoid conjugate vaccine or the typhoid polysaccharide vaccine, and the response to the booster was studied about 6 weeks after the booster and also followed up till the end of 5 years. This vaccine has been recommended from the age of 6 months. Will a single dose be effective in children who have been vaccinated as early as 6 months of age? If you look at this particular bar diagram, you please concentrate on the 4 graphs. The first 2, the light or the dark orange and the blue, are those who have received the age group of 6 to 11 months, and the next 2 are cohorts between the ages of 12 and 23 months. Please note that the antibody titers are similar in both the age group, indicating that children even as young as 6 to 11 months have elicited a very robust immune response compared to the older infants. The next question that is to be discussed is, can the typhoid conjugate vaccines and measles MMR vaccines be administered concurrently? If you remember, till recently, for various reasons, it was recommended that the 2 vaccines should be spaced at least 4 weeks apart. So the manufacturers of Typhoid TCV conducted a measles TCV interference study. They had 5 arms. One group received measles and TCV both. One group received only measles and one group received only TCV. One group received TCV at 9 months and measles at 8 months. Another group received measles at 9 months and TCV at 10 months, that is after measles. All these permutation combinations were basically to see whether there was any interference between the 2 vaccines, even if they were separated by varying time intervals. Please concentrate on this graph and the rectangles that have popped up. The first 2 bars are where there has been co-administration of TCV and measles vaccine. The blue bar is where TCV alone has been given. And if you look at the serum via IgG titers, the geometric mean titers, they are statistically no significant difference between these 2 groups. In fact, if you see, the group which has received both the vaccines have mounted probably a little higher antibody response. This shows that co-administration has no effect on the antibody production against the typhoid component of the vaccine. If you look at this bar and concentrate on the first 3 bars, the first 2 bars are the co-administrations. The blue is where measles alone has been given. Even here, there is just no difference between the antibody response in these 3 groups, again indicating that the response to measles vaccine is in no way inferior if the vaccines are administered together versus vaccines administered separately. This data is sufficient to convince us that measles MMR and the typhoid conjugated vaccine can be administered simultaneously. Now, will the conjugate vaccines, we all know that it's going to be a pretty expensive vaccine. Now, is this vaccine going to be cost effective? This is a projection model study where they studied the cost effectiveness of 5 conjugate delivery strategies in 3 urban areas, both in Delhi, Calcutta and in Nairobi, and in 2 regional settings in Kenya and Vietnam. What they did is they compared routine vaccination of 9 months of age as one particular strategy and routine vaccination 9 months with a one-time catch-up. That one-time catch-up was done between 9 and 5 years in one group, 9 months to 15 years in another group, and 9 months to 25 years in the fourth group, and all ages above the age of 9 months. What they concluded was that routine vaccination with the conjugate vaccine would be cost effective in most settings, and additional one-time catch-up campaign would also be economically justified. So basically what this study shows is that firstly, conjugate vaccines are definitely cost effective. Routine immunization 9 months plus catch-up at any age is definitely an economical measure compared to not vaccinating at all. So with all this robust data behind the conjugate vaccine, in 2018, the WHO came out with a position paper on typhoid vaccines. It recommends the programmatic use of typhoid vaccines for the control of typhoid fever in the context of other efforts to control the disease and not as an exclusive measure. TCV is clearly preferred at all ages over the polysaccharide vaccine. WHO recommends the introduction of TCV to be prioritized in countries with the highest burden of typhoid disease or a very high burden of antimicrobial resistant Salmonella typhi, and India satisfies both these criteria. The position paper also went on to make specific recommendations. Primary vaccination as a 0.5 ml single dose for infants and children from 6 months of age and in adults up to 45 years of age as a 0.5 ml single dose in typhoid endemic areas. WHO also encourages routine programmatic administration of TCV at the same time as other vaccine visits at 9 months or in the second year. Basically, it can be co-administered with any measles containing vaccine. Catch-up vaccination is also been recommended up to 15 years of age where feasible and supported by epidemiological data. The position paper also mentions that the potential need for revaccination with TCV is currently unclear. The special populations which need vaccination are professional food handlers in typhoid endemic areas, travelers from non-endemic to endemic areas where any of the 3 vaccines can be given, all healthcare workers, pregnant women where the risk of typhoid is more than in the general population, and all HIV infected and other immunocompromised persons. The Indian Academy of Pediatrics Committee on Vaccines and Immunization Practices has come out very recently with its updated recommendations for immunization in children aged 0 to 18 years. Now, regarding the typhoid conjugate vaccine, the recommendations are a single dose of TCV 25 micrograms is recommended from the age of 6 months onwards routinely. An interval of 4 weeks is not mandatory between TCV and measles containing vaccine. They also have gone on to make a recommendation that for a child who received only typhoid polysaccharide vaccine, a single dose of TCV is recommended at least 4 weeks following the receipt of the polysaccharide vaccine. A routine booster as presently practiced at 2 years is not recommended. Here it is worthwhile mentioning that both the ACVIP and the WHO have specifically recommended the 25 microgram dose because robust data about the utility of the 5 microgram does not exist as on date. We have a very strong base of immunological data, that is data based on antibody titers at different periods following the vaccination. But we do not have any efficacy data of this particular vaccines which we are currently using. A large study has been initiated in Navi Mumbai by different sponsors from all over the world, where the primary outcome is a blood culture confirmed typhoid fever up to 24 months after vaccination, and various secondary outcomes like AVFI, the vaccination coverage impact, environmental contamination, etc. Over 4 lakhs children are proposed to be vaccinated in 2 phases. The first phase is already over, where over 1.5 lakh children have been vaccinated. The second large study is being initiated in Malawi, where about 24,000 children aged 9 months to 12 years have been vaccinated with the TCV with the meningococcal A vaccine as a control vaccine. Similar endpoints, both primary and secondary, are being studied in this study, and once we get the data from this study, which we will not get probably till end 2020, we will have very robust effectiveness data as well, and that will give us much more confidence in using these vaccines in the NIPs. To conclude, globally and in India, typhoid is a major health problem. Typhoid in infants is a significant problem in India. Vaccination is an attractive short-term solution. The conjugate vaccines have been shown to be superior to the polysaccharide and oral vaccines. The conjugate vaccines elicit strong protective response in subjects from 6 months onwards. Protective titers have persisted till 5 years after vaccination, with boostable responses in the entire cohort. Measles containing vaccines do not interfere with the response to the typhoid conjugate vaccines. The need for boosters in endemic settings is uncertain. The conjugate vaccines have been found to be cost effective in developing countries, and the WHO strongly recommends the use of the conjugate vaccines in the NIP in countries with a high and heavy burden of typhoid. Thank you.